Today's session will start with the cardiovascular system. We'll go over anatomy. I'll provide some supplemental link lectures. These links are not published as public, so you can't find them. These are only through the link. In case you want a deeper dive, or you want some other supplemental resources that are from yours truly, not just some random Nerd Ninja, which is great. Nerd Ninja is really good. Other platforms are really amazing. But if you want to hear me go over content, I have a list just for you guys to use, okay? And I normally cover every system from start to end. So from your integument system to the reproductive system. When we go into medical school, we specialize in certain topics, and there's a few topics that we focus really into. All right, so those are there for you. So our story today begins with a quick little tour of the heart. And if you've taken undergrad anatomy, a lot of overlap here, but there's some small clinical applications which might be exciting and help open your mind to the understanding of this cardiovascular system. So the heart, you may have heard, is really a double pump system. That means the upper chambers, which contain two rooms called the atrias, their role is to get and receive the blood and pump the blood down. Down where? Well, there's another two rooms below those two chambers called the ventricles, right? So you have the atrias and the ventricles. You have a right side and you also have a left side. So if you look at the picture, so left side over here, right side over here. 4 rooms, 4 chambers. In order to go from one room to one room, there has to be a door that allows you to pass it through. Right? So on the right side, and this is just a quick way to always know your valves very clearly, is you always have to try something before you buy something. So on the right side, you're going to have your tricuspid valve. This is the first door that allows the blood to enter in, deoxygenated blood coming down from the body. And then on the left side, you have the tricuspid, okay, that exits out. Okay, so simple, 4 doors, 4 rooms. We'll get into some of the substructures in a second here. When you look at the flow of blood, make sure one way to help you very clearly understand this is just trek along the black arrows. And when the SVC, the superior vena cava, the IVC, the pulmonary sinus drains in, their main job is to fill the upper atrias, and there's an amount of stretching that occurs. In the very first phase of the cardiac cycle, so when you think about your heart's contraction and relaxation, if you were to freeze and slow down every frame of contraction and relaxation, it could be dissected into about 4 to 5 different actions. There's a filling phase. There's this brief isovolumetric period. Then there is going to be another ejection phase. And then there's another filling phase, and it fills up again and injects again. Okay, so it's really a back and forth between filling and moving the doors open, the valves, filling it up to the point where it's getting ready to squeeze, and it contracts again. And I'll show you guys that. That's maybe a little bit of physiology, which you'll probably cover in another class. But just be mindful that in my slides, when you're going through all the different classes and getting ready for the midterms, pay attention to anything that I have in bold or anything that's in highlight. All right, and also some stars. So whenever you see the little stars, that means high yield. Make sure you know the terms. And I like to teach the anatomy physio in the sense that not everybody has the same exact level of understanding. Some of you folks in here probably took anatomy in undergrad. Maybe it was a few years ago. Maybe took it last year, last summer. Some of you guys probably never took it before, or took a crash course version online and just really quickly downloaded and then spat everything out and forgot everything. So we want to have a nice level of baseline understanding for everybody. So over here you can see, as the right side image shows you, each phase of this filling and opening moves the blood through, and there's these valves that ensure the flow of the blood. The key function for most of our valves is to do what? Any ideas? What's the purpose of these valves? The tricuspid, the bicuspid, the semilunar, the pulmonary, the aortic. What's the point of these doors? Really good. Okay, so regulate the blood flow. Basically, they don't want to prevent any flow of blood back. You're preventing something called regurgitation. All right, so you do not want the valves to become weakened or prolapsed, meaning it flaps backwards during the pressure contraction. So a healthy set of valves are going to be attached to some structures, which I'll show you in a second. These are little heartstrings called the chorda tendineae. These are fine little fibers composed of collagen and elastin. So a lot of the stuff, if you don't see it on the board, it's fine. You're going to see it in a second, but just kind of giving you that picture of how the valves work so that the blood is moving in one direction. A lot of the pathologies, which I'll briefly describe, you don't need to know all of them, but there's a few that are relevant, involve when the valves starting being really, really squishy or maybe flappy, and they're not able to close entirely. Then you get the mixing of the bad blood, which is the deoxygenated blood, with the good blood, the oxygenated blood from the lungs. Then as a result, what happens? What happens when you don't get adequate amount of oxygen delivered to your body? What does your heart do to compensate? Anybody? Would you beat faster or slower? Faster. And over time, when your heart's beating faster, there's going to be remodeling. Okay. The issue with the heart and muscle is that anytime, and some of you guys like to lift, when you're working out your muscle, your heart is also muscle. If you contract it over the course of time and you allow this to happen years and years, there's hypertrophy. And that remodeling can take place in two forms. This is actually what's really fascinating. Number one, it could happen where the volume of the heart enlarges. Okay, that means you're pushing so much blood into the heart that you expand the heart bigger and the walls are more thin. That's going to be volumetric based remodeling. The other kind of remodeling, which some cardiologists will see, and this is where you have to go in with the angiogram or you have to go in invasively to see it, is the muscular hypertrophy. So the ventricles get so much thicker, but the volume is smaller because you're pumping so fast. And this ties right back to all those cardio issues with blood pressure, hypertension, all that stuff. So it's a time bomb. So in other words, if you have an enlarged heart, it's never good. Okay, so proportionally to your body, if your heart is substantially larger than the size of your palm or fist, there's an issue. There's some sort of pathology in there waiting to occur. Okay, so the two terms to be mindful of is the term diastole. This is going to be the term for filling up the blood into the chamber of the atria, and then the systole is just going to be contraction. So the cardiac cycle is a combination of atrial diastole, atrial systole, ventricular diastole, ventricular systole. Okay, so it goes back and forth. But what happens is if you freeze this picture, I know this picture isn't moving and this is not the best image ever, but the top part is going to expand first. It fills up, blood gets ejected down into the ventricles. You can see the volume of the two sides over here on the bottom aren't too great. As the blood fills up, it stretches. Now this part gets expanded and pressure builds up, and then it contracts, ejects the blood out. Okay, so there's a brief moment. If you were to freeze it, it looks like this. So atria is on top, ventricles on bottom. So top squeezes first, relaxes, then bottom squeezes, then relaxes. So really, it's double pump. But from far away, it looks like it's one synchronized action. Okay, but it's top first and bottom. And that's because of the muscles we'll go over. And in each of these chambers, there are slightly different musculature. So for the heart, we have a couple of layers that you have to be aware of. First one, the inner layer is called the endocardium, the lining that actually touches the blood. This is also an extension of the valves. So when you hear about COVID a few years ago, we've all heard an earful of that, right? Endocarditis. That's when you have the inner lining of the heart chamber inflamed. And the biggest issue with endocarditis is what structure is connected to the endocardium? The valves. All right, the valves are a direct extension of the endocardium. And so when that place gets inflamed, that can cause changes to the chordoteninae, affect the way the valves work, then you might have to get some kind of artificial valve. Prosthetic valves aren't good. Anybody heard of what happens in prosthetic valves? If your valve gets kind of flappy and leaky, you can choose to replace it with more bio-friendly materials, but years ago they have more non-bio-friendly. What happens in a prosthetic valve implant? That's number one, right? So first of all, there could be rejection. What happens to the blood? What happens to the blood flow? Turbulent, okay? And also because the prosthetic valves might not be nearly as flexible, it's actually killing off your red blood cells, your erythrocytes, as it's passing through. So you can become more anemic. You're also becoming hypoxic because the cells are physically getting damaged as it's passing through those valves. Okay, so those cases are oftentimes linked together, but that endocardium. The second layer is the myocardium. This is the thicker layer of the muscle. This is the density, 90+% of the entire tissue of the muscle is myocardium. And this is where you have the tissue that then hypertrophy enlarges. And the epicardium on the outside is out of two layers. The epicardium has two sublayers. There's a parietal and the serous. This is that double layer membrane where there's a slight fluid film gap that helps you limit the size of your heart, number one, but also maintains so that when you expand, it doesn't overload. Okay, so it limits how much you put in. When you're thinking about the blood flow, you're talking about 70 mLs of blood every time it moves. Okay, so you have the stroke volume, which is the amount of blood your heart ejects in one squeeze. And if you don't get that rough estimate about 70 mLs, and let's say you have a blockage or your muscles are just not as healthy, you had a heart attack, a myocardial infarction, and you survived, and you have less muscle to use, then that means the 70 mLs is a lot lower. Your heart has to do what? You squeeze twice to compensate for 70. So instead of pumping 70 mLs of blood, you pump 30. So that means that person has to pump twice for every time I pump. Over the course of a year, your heart is working twice as hard. Make sense? So that load is the issue, okay? Over here on the right side, just be mindful. Embryonic development, the heart, you can see, it's really small. There's a serous membrane. Fibrous pericardium is the outer layer right here, then very thin outer layer, and there's this double membrane where there's a fluid reducing friction. Inside you have the heart developing, and then the aortic arch branches out, and then this is eventually giving rise to your myocardium, epicardium, and endocardium. As far as the contraction goes, the action, this is interesting. So heart contractions is mostly of a twisting ring motion, okay? And when you look closely at a beating heart, the ring motion is based on the fibers of the myosin actin of the myocardium. And if you look at the picture on the right, you can see that the ventricles actually wrap around each chamber. Okay, they wrap around. So that twisting motion is like ring a mop. So if you really had to look at how the contractile fibers overlap, and in the beginning of today's session, I talked a little bit about myosin actin. So these are two contractile proteins. Myosin is also known as a thick filament. It has the myosin heads that link up to a thin protein called the actin. Okay, there's some regulatory components on it, like troponin, myomycin, nebulin, but the two proteins link together to allow cross bridge to occur. Cross bridge is a fancy way for saying linking the two fibers so you're able to then have ATP and move the fibers along. The length of the fibers don't change. Contraction is simply just an overlap of the fibers. All right, so just keep that in mind. Whenever you move your muscle, arm, you're doing a curl, your heart's contracting, it's a matter of the overlap of the fibers. All right, and then over here, one of the skeletal system that maintains integrity of the heart and gives it to that shape is this fibrous framework of dense collagen known as the annuli fibrosi. This is a set of rings like the skeleton of the heart, and they form the foundational structures by which the chambers are limited. When there's remodeling, in the beginning I told you guys about the pathology where you have the volume overload or maybe you have the muscle overload, you're changing the integrity of the skeletal system. And some key functions here is that this is the key attachments for most of the leaflets and the valves. I have a slide that goes over the valves specifically. They are also an attachment for this ventricular myocardial band. So there's a ring of muscles that are different when you look at the atrias versus ventricles. The atrias have a set of muscles called a pectinate. Okay, and you'll see this in a later slide, pectinate. Inside the ventricles, because it's so big and it has to move the blood to the body, you have another set of kind of fibrous muscle tissue called the carnate, trabeculae carnate. And those muscles are there to do two things. Number one, you do not want the ventricles to stick together when they contract, right? Imagine that. If it contracts and somehow that chamber does not open up or does not have the way to refill, that's an issue. And number two, you also want to be able to have some space and to generate a higher contraction if needed, right? In case you tap into your sympathetic nervous system, right? You may have heard about this a little bit in some other courses already. There's the alpha 1, alpha 2, beta 1, beta 2, but the beta 1, that's your heart pump, right? That's what stimulates contraction, contractility, ionotropy, meaning the speed and conduction. So you send a faster speed through the heart, you're going to get a more powerful contraction and more blood coming out, okay? We'll talk about the nervous system later on, but just for everybody here, there are 4 different receptors, the alpha 1, alpha 2, beta 1, beta 2. Beta 2 primarily found in your bronchial dilation of the airways, found in all the blood vessels of the human body, also found in your GI. Beta 1 mostly in the heart. Anybody have an idea where alphas are? What's alpha receptors? Really good. Well, and what do? Do they dilate or constrict? Constrict, okay? So real quick here, alpha 1, alpha 2, what's the difference?
Alpha 1 sympathetic, alpha 2 is parasympathetic.
Not quite. Not quite. Smooth muscle. They're all so. This is what's actually really fast. It's great. This is good. This is exactly what we want. It's Saturday morning. It's all good, guys. Saturday morning. You probably didn't get your caffeine in yet. I see the volume of the caffeine. So by the way, I've taught for so many years that I can gauge the level of Starbucks or Dutch Bros to know the level. So once that cup goes down, I know I'm losing you a little bit. So that's why I kind of gauge that. If you have like a cover over, I can't see it. But okay, so the whole point is alpha 1 is a constrictor. It's found in blood vessels. It's going to be a smooth muscle. Alpha 2 is very unique. Alpha 2 is considered an auto-regulation receptor found in your CNS. It's only primarily used in your brain. And this is also why certain drugs like hypertensive drugs, clonidine, have a mechanism to target the alpha 2. And you're thinking, if it constricts, so think about this. If alpha 1, alpha 2 constricts your blood vessel, why would you give a patient with hypertension, right? They have a high blood pressure. It's over 150, 160, 170. Systolic, diastolic, super high. Why would you give them something that binds to the alpha? Wouldn't you want to dilate it to reduce it? Why would you give them so the treatment is clonidine. Okay, you guys will probably see this in pharmacology or pharmaceutics, but clonidine is a commonly prescribed drug that's used to agonize, which means it binds to the alpha 2 receptor. Alpha 2 constricts, right? So think of it like a hose. If you've ever gardened, you have a hose and you decide to squeeze down on the hose and make the volume or diameter of the hose smaller, that water pressure is way higher. It's going to shoot out. Akram. Really good. So beta blocker is one. You can kind of reduce the amount of epinephrine or epinephrine binding and reducing calcium. Calcium blockers are also used as well in the heart. But what about alpha 2? This one's very unique. And I think this will be a good opportunity. So hopefully one day all of you guys come across in medical school and you get this question, you'll remember. Alpha 2 is one of the unique. There's a few of these receptors in the body where there's unique circumstances. Alpha 2 is one. And the reason is because it's an autoreceptor. So what that means is when you give the patient that chemical to bind that receptor, in the beginning, it constricts. But the body begins to pick up and say, hey, we have this chemical that's binding the alpha 2. We don't need to make any more of it. So in the long-term effect, is it actually dilates. The initial short-term effect is it constricts, but because you're giving the patient this drug for a couple of weeks or so, the long-term effect is it actually dilates. So the reason I use this one is because when you talk about cardiovascular issues, hypertension always comes up, right? High blood pressure. And clonidine is one very unique mechanism. All the other ones are just more whatever it binds, whatever it does. Okay, so hopefully that can help you a moment there. Yeah, Crystal?
So since it's like mainly the brain, but I feel like I remember maybe learning that it was also like in the bladder. So does it have, would clonidine essentially just still do the same thing in both places as well, or is it more specifically just targeted to the brain, past like the brain, the blood-brain barrier to do that?
Yeah, so once you get the drugs in your body, you don't determine what receptors are most responsive to it. It circulates around the system. But when you think about hypertension, the first and foremost, the most important region that you want to take care of is your brain. And so that part gets affected. Actually, the other part where alpha 2s are found is GI. So you have some in your GI system, but not as high as in your brain. So people don't realize it. And what's also fascinating is as you come across this course and this year, you hear a lot about blood pressure and drugs and anatomy. But epinephrine, adrenaline, right? These two chemicals essentially are cousins. They're the siblings. They're one reaction apart. Okay, so all these chemicals from dopamine, tyrosine, there's several reactions apart. And epinephrine technically is more of a hormone than a neurotransmitter. Norepinephrine is more of the neurotransmitter version of the signal. Okay, so just don't forget that when these chemicals bind to your body, your brain is also going to be responsive as well. Okay, and then last part for the fibroskeletal system is I want to highlight that this is also the foundation for the AV bundle and conduction system. Very briefly highlighting this is that there's a set of pacemaker cells in your heart. The sad truth and analogy we always use is that the heart is controlled by 1 or 2% of cells. Right? It's like the world's wealth is controlled by 1 or 2%. So the whole point is that you have the SA node, AV node, Purkinje fibers, bundle of His, and they run from the upper atrial chamber. So I know this is not showing you, but upper chambers from the right atria, cascading down towards the right base of the atria to the left atria, then through the middle septum of the heart, right in the middle, and then the ventricles. And that's also why in the beginning of today's talk, I said the top part always contracts first, then it relaxes, then the bottom contracts. So a signal must be provided first on the top for it to contract, okay? And anybody have an idea of what's the difference between these pacemakers? The sinoatrial node, the atrioventricular node, the bundle of His, the Purkinje fiber. Why do we have 2 or 3 sets of these?
They have control different rhythms.
Good, so the speed, right? The speed by which the action potential is generated is slightly different, really good. But why do we have so many of them? Why not just like one?
Redundancy. If the SA node fails, it goes to AV. If that fails, it goes to Purkinje.
Really good. So you probably took anatomy before, but really good thought process. Really good thought process. So that's the way to think of it, right? So think about this is that you want to have backup. So the SA node has the highest rhythm, about 70 beats per minute signals. AV is a little bit lower. Purkinje fibers, you cannot run on that by yourself, right? Your heart would be too slow. You would not get adequate perfusion and effusion from the movement of the blood. All right, and we'll talk a little bit about issues, but it all comes down to, are you able to get that stroke volume consistently to meet your body's demand? The 2 concepts I'll add towards the end is you got to think about this. When you're sitting down in the chair, and you guys all will be here for a few hours sitting, and you're like, oh, I don't feel really good. Sitting's a new smoking. One of the issues with sitting is you are also depleting the amount of venous return from your body to your heart. So if you're in a bad posture, and not enough blood is coming back to your heart, what happens? Does your heart work faster to get the blood or slower? Faster. So when you're sitting down and cutting off supply from the legs and you're not breathing, if you're breathing, you're moving the blood. So by the way, when you're moving a diaphragm, you're moving the blood. But if you're sitting for X amount of 6-7 hours and you're not moving, your amount of effusion and the amount of blood flow to the body is also diminished. And that's an issue. Okay. So it all comes down to the return of blood and also the ejection. Key structures of the heart, when the external anatomy goes, is we have a few key borders, and a few key zones here. So on the upper part of the heart, we have the base on the top. So remember, for the lungs, the base is on top, apex is on the bottom. The lungs is flipped around. So apex on top, base is on the bottom. The key borders include the right, left, superior, inferior, and surfaces are the regions that it touches. We have anterior chamber to the thoracic cavity, diaphragmatic region on the base, and then we have on the right side and left side the 2 pulmonary. Okay, I want to make sure everybody's aware of this. When you look at most anatomy books and any kind of cartoon image, for example, the one on the right, when you look at the vessels of the human body, the red ones are typically colored as representing arteries, right? They carry the oxygen-rich blood that's passed through the lungs. The only set of arteries that are not colored red are which one? Pulmonary. Everybody see that? Okay, so look on the screen. You guys can look around. But this pulmonary one on top, these ones are going to bring the blood that is not yet. Because, again, one way to think about this, aortas or arteries bring the blood out of the heart. Veins return. But when the right side of the heart pumps the blood to your lungs, is the blood oxygenated yet? No. Okay, it hasn't gone through all the alveoli and the little bundles to pick up the diffusion and drop off CO2. The hemoglobin hasn't touched the oxygen. And as a result of that, as it comes back in, then it's the oxygenated version. Okay, so the pulmonary arteries are going to be leading the blood to your lungs, but they are usually colored in blue. And the red ones on the posterior side, and during the HoloLens and the anatomy cadaver, I'll show you that, they return in, and these ones will be rich. Real quick here, I'm going to cascade to the platform that I want to show you. So over here, for the lab exams, and whenever you have, anytime I come into class, for my, I got to do it. Can I do attendance at the end? Because I'm on a roll right now, so I got to put that in. So what's going to happen is whenever I have the lab class and when we have exam questions from me, I will provide you with images from a list of cadaveric slides. If you go into the Brightspace for the class, I always will have the PowerPoint for the lecture, and then for the lab part, I'll have a list of cadaveric images. Does anybody see that, or have you guys downloaded it yet? It's pretty high resolution. It will take a little bit of time. But one of the questions I've always had over the years of interviewing for students here, 2 years, I feel like I've taught for so long, is that they always ask, well, at CHSU, we don't have any cadavers. We don't have any cadaver lab. And I think there's pros and cons. The pros is that obviously the cost for the school. Some folks might not be super comfortable working with a cadaver. Maybe there's a little bit of fear, religion, culture, any kind of reason. But what I'll do is I will provide you with a set of slides that have different structures that are cadavers. So nobody has to do anything dirty. Your hands were not getting stained or any way, shape, or form. Somebody else did all the dissection, and it's also really good. So this is showing you the real heart, and we can tease it to different structures. So what I'll usually do for the slide is, this one's more interactive. I can strip it all out. You can see what a real atria looks like. That's the superior vena cava, inferior vena cava. IVC, SVC, pulmonary sinus in the back, aortic arch. But first thing first is what? The real cadaver heart is definitely not nearly as clean and perfect as a model. Right? So if you're used to studying a perfect cartoon image and everything looks perfectly symmetric, you're fooling yourself, right? So it's good to kind of make that jump, compare it a little bit. Okay, you can see over here the chordae tendineae. These are the white strings, heart strings. They're attached to the valves. And on the base of this region, this is going to be the region where there's the trabecular carne that you can't see fully, but the muscle density is way lower on the right ventricle than compared to the left side. Right? You can see on the left side. So we'll strip it a little bit more. Over here, you can see it, you tease it off the layer, and you can see the density of the fiber. Further in, you can see the septum. So this is the dividing border, right ventricle, left ventricle. Just by the size, you should know that. Right, so when you're looking at the heart dissected, the side that has much more myocardium is always the left. Okay, and depending on pathology or what age or what kind of how well it was preserved, it could affect the visual. Right, and so what you will see in the, let me just show you where to find it. So whenever you go into the lab, the images that I will use for the exam, because for our midterm and our final exams, the way the questions are structured is there's always going to be a set number of questions pertaining to every lecture. So it's very equally distributed. We have like 6 or 7 questions from every lecture, and then 3 questions for lab-based or image-based content from that topic. So for example, today on the midterm, you'll see 10 questions from me. The remainder will come from Dr. Richards when she went over the circulatory system, the planes, terminology. You guys went over embryology, correct? Yeah, so all the other topics will have about 10 questions per piece. And of the 10, it'll be about 6 or 7 of them. And don't worry, we'll do our recussions before we leave as well. Okay, and the worksheet that I provided there and the content is basically a similar version of the questions. So what we'll do during lab time is I'll usually pick out the key items I want you to look at. And all these images are very clean. So I don't know if you guys all have taken, who's taken anatomy before in undergrad? All right, most of you guys. Some of you guys haven't, but if you take an anatomy class, you probably in undergrad probably use like a cat or a pig or a sheep's heart or a cow's heart or something like that. And so the cadaver images that I have here are all human, very, very clean. They're all highlighted with the structure and then the term. So what I will do, and because this is anatomy, is I will just have this image on the question, and I'll just say, identify this following structure. Okay? The images that I will use are going to only come from this list. So you won't get some random Google picture from some random old textbook that's kind of fuzzy. None of that stuff. Okay? So what you see is what you're going to get. It's good to be mindful that these are real ones. So when you look at some of these vessels, they're not as perfect as a cartoon, right? If you look at, I'll show you one. So over here, if it wasn't colored, it's almost very challenging to decipher between the pulmonary veins and arteries, right? But you'll see there's 2 sets over here. Over here, this entirety is the outer atria. It's not dissected yet. Ascending aorta right here. The arch has been cut off. Over here, we have the vein, the coronary sinus. And we'll talk about the vessels as we get along, but you can see the IVC on top, and then IVC on the bottom, and SVC on top. Okay. So just as you're going through your list of structures, this is the image bank that I will use for my questions. That way you don't have to go scouting or searching or scavenging for any images. It's right there for you. go back. Okay, so we should have our first top reference coming up. So I have some questions embedded in here. So let's move on. Now, next over here, we're going to jump into each chamber. So this is where you want to pay attention. Each chamber has key structures that I want you to identify. So when you tease open the right atria, a few things to be mindful of is you have the pectinate muscles, which I briefly mentioned in the beginning. The key functions of the pectinate muscles here that you see on the right side, all these little line fibers, is so that it limits how much the atrias can expand. You don't want venous filling to overload the atrias. As a matter of fact, that's an issue. Because when that happens, you won't be able to pass the amount of blood to the ventricles to get it adequately shunted across the lungs, not the body. Your heart works twice as hard. And you never, ever wring the heart dry. Okay? So when you're contracting your heart, you never squeeze every drop of blood out. It's about maybe a good 40 or 30 mLs of blood still residing inside your heart at all times. And then there's a structure called the sinus venarium. This is the smooth entryway by which all three of those key blood vessels enter the blood back in. The SVC, the IVC, right? SVC stands for superior vena cava. The IVC stands for inferior vena cava, and the coronary sinus. These three main vessels drain in smoothly at the sinus venarium. Okay, that's the location of the entryway. Inferior to the right atrium, you're also going to see these smaller bridges. The crista terminalis is the border between the first pacemaker and some of the muscle. And there is a distinguishing setup. So when you look internally to this, if you look over here, there's a smooth groove right here, right? You see that smooth groove? The pacemakers are not highlighted in a color. These are just a very minor, small percentage of cells that have that signal ability to fire the action potential. All right. And then when the action potential depolarizes, the calcium ions flood in. As a result of the calcium, it releases troponin from the actin, and the myosin and actin link up, and you'll have contraction. There's also going to be a little opening, the remnant of the foramen ovale in the fetus. This is the shunting of the blood. This ovale is what then fuses to become the patent. And in some cases, you may have some non-life-threatening foramens opening between the chambers. You might just have a little bit of murmurs as a result of that, but it's not lethal. And that foramen is because the embryo, the fetus, doesn't have a fully functioning lung, so it shunts the blood from the right side to the left to get it to the body. Okay, so these are some of the key structures here. There's a little bit of overlap in the left atrias, but there is definitely more pectinate muscle. We'll put a start to that. Much more pectinate muscles in the right atria than the left. So if you were to dissect the heart, and you're looking at a heart that's not well preserved, you're like, which side is which? The side that has a higher density of pectinate muscles is the right atria. Okay? So if somebody handed you a heart one day, and you're like, is this the left or right side? That's one way to know if it's right or left. Thicker, denser pectinate muscles is going to be on the right atria. Good. Next one. So we go down from the right atrias down through that first door. What was the first valve called? Going from the right atria to the right ventricles? Tricuspid. Okay, really good. And then as you go down, this is a region where you're going to have this kind of cone-like structure, and you're going to see the setup of the valve. So on the right, I know it's very, very small, but these valves, these cusps, are attached to the chordae tendineae, these heartstrings. And at the base of each of these heartstrings is a set of muscles called the papillary muscles. These are another set of tiny little ridges, which basically give it the integrity to help the valves not prolapse. As the blood is pushing through, there's going to be a little wheezing, a little bit of turbulence, but the valve shuts based on the pressure suction. There's a really, really cool graph, if you're ever interested on how the pressure changes, which is called the Wigger's diagram. That maps out the changes of the pressure points as blood is going through. So as the pressure builds up, right, it's going to, when it contracts, the pressure builds up. When it fills up and relaxes, the pressure goes down. So it's a pressure-driven suction that closes the door. Inside the right ventricles, you're going to see a little bit of the irregular muscular elevation called the trabecular carna, and this is only found in ventricles. So if you were to look at a dissected heart, which side are you looking at, the atrias or ventricles? Trabecular carna is always going to be ventricles. And then we also have a little crest region, which is a small divider border that separates the inflow and outflow of the blood, because there is a region where the blood comes in from the tricuspid, and now it exits out the first set of semilunar valves called what? What's the first set of semilunar valves called? Is it the aortic or pulmonary? Pulmonary, really good. Okay, so it's leading to your lungs. So it's a pulmonary semilunar valves. There's 4 doors. Okay, 4 doors, 4 names. Over here on the right, you can see a small picture of the valve. So when it closes up, you can see direction of blood flow. When the valve opens up, it squeezes, the cuffs come down, and blood goes in. And as it closes, it shuts down. So in some cases, these valves can be somewhat weakened if there's lesions in there, or there's some sort of myocardial infarction, heart attack, and that region got damaged, cutting off blood flow to the region. You can also have myocardial effusion, where there's fluid accumulation that squeezes on a chamber. And if it's squeezing the chamber so hard, it may affect the amount of closure that the heart has. And then over here on the top, you can see the trabecular carne, just thick ridges throughout. And then the crest is shown here. There's a small little ridge between the 2 grooves. And right above it, is the valve, okay, the pulmonary similar. So you can see there's 3 leaves. Most of these are going to have 3 leaflets, except for the mitral. Okay, the bicuspid or the mitral valve is the only one that has a 2-door closure. All the other ones have 3. That means they also have how many papillary muscles? At least how many? 3 sets. Okay, so there's 3 sets that reinforce it to bind to it. If any one set becomes compromised or weakened, then there could be issues. All right, so keep going. Next one. Quick, see if you guys can see this question. So on your guys' top hat, you should see this. This is not going to be for points. I just want to see if you guys are still with me, or Saturday morning you're just sleeping with your eyes open. That's another skill I've seen students be able to do. So go ahead and type into the response here. So how does the trabecular carne contribute to the functionality of the right ventricle? So brainstorm it, talk with your TBL groups, and then hopefully we can see some responses. You should be able to post directly on there. And I think you can also draw as well. So you can just draw onto the screen. Can you guys see all this, or are you guys not able to see any of this? On your computers or your phone? Yeah? Let's go ahead and test replies. So test something. Just okay, cool. Nice. Great. Cool. Okay, yeah. And you can modify it too. So just go ahead and type in what you think. Give you guys a few moments. And we'll take a break after we go over this, and then we'll come back. Let me pause. With the anatomical position. So that means you're looking at how you see me. So put together, palm facing you, whatever organ is displayed in your anatomical view, that's your view to start labeling and memorizing the structures on that item. Okay? So always orient the model to its anatomic position, and then once you have an idea of the different areas, then you could look at the posterior, transverse cut, sagittal cut, coronal cut, however you want to slice and dice that off the model. Okay. Anterior papillary muscle, this is going to attach to the largest cusp, and then we have the posterior one, a little bit smaller on the posterior side, and the septal is the one on the midline. The septum is super important. There's a lot of cardiovascular pathologies related to ventricular septal defects, VSDs. That's actually one of the more common deformities. When the septum, the middle border of the left and right ventricles, is deformed, you compromise the amount of blood coming in. You also can limit the amount of filling. You can also cause overfilling. So just remember, the septum is where a majority of deformities occur. And this also means that there could be also potential effects to the septal papillary muscle. There is a small little tight bundle of muscle called the moderator band. And this region is what kind of accumulates at the base of the heart. So not base, the apex. So towards the bottom border near the apex is a region where all the muscles kind of collide together. Right at that area, you have the moderator band. Okay? So that's another feature that if you're looking at the right ventricle versus left ventricle, and how do I know which ventricle it is? That's an internal anatomical structure that you can use to identify the left and the right. And then once we get into the left atria, it's basically another mirror image to the right, except for the fact that it has less of what muscle? Pectinate, okay? A little bit lower density of pectinate muscle. This is where most of the pulmonary veins, right and left, are going to then come back in. It's a little bit thinner. It's also, slightly thicker, but a little bit smaller in volume because of the amount of blood coming back in. It's limited. And then this is what receives the blood flow back to the ventricles. And right here is a view showing you really closely that foramen ovale. This is the opening that was once allowing the baby's left and right ventricles to communicate, and now it's fused together. If this was not completely fused, the disease is called PFO, patent I'll write this out. It's called PFO, patent foramen ovale. That's the condition where when this foramen ovale is not completely fused. A majority of the population will have variation, and what makes the heart so fascinating is that in pathology, you have a percentage, maybe 40-50% of folks, when they have a heart attack, it comes from the left coronary artery, the left side. You might have a subset of folks, 30-40%, 35%, coming from the right. And then you might even have a minor 15% that comes from a very small branch of the circumflex. So pathologies can vary. The amount of blood vessel breakout also varies too. For example, the small vessel that supplies the pacemaker cell, the nodal cell, not everybody in this room has the same branch. Okay, we all have the main branches, right? We have the RCA, LCA, right coronary artery, left coronary artery, coronary sinus. But the smaller sub-branches like the nodal branch, the SA nodal branch, the AV nodal branch, that's not found in every person in the population. So there are variety and deviations. Okay, and then last but not the least is your left ventricle. This forms the apex of the heart. This is where you sit in with a double leaflet mitral valve, aka bicuspid. There tends to be a little bit more density of the trabeculate carne. So when you're identifying the left ventricle, the very first thing you should know is that there's a lot thicker layer of this myocardium. That's number one. Number two, inside the internal region, you'll see a lot more webby-like structure, irregular. That's your trabeculate carne. And the region that leads the blood out to the aortic semilunar valve is called the aortic vestibule. If the aortic vestibule gets calcified or damaged, then you will also restrict the amount of blood coming out. Right? You could have appropriate blood entering, but if you're not allowing the right contraction, the right movement of blood out, then you're also going to have an issue of compensation. All right, so let's take a quick break.